Before we begin our program, I would like to highlight a few housekeeping items. Today's webinar will include a lecture followed by a question and answer session to allow the faculty ample lecture time to cover the materials. However, you may submit questions to the faculty at any time by typing them through the chat feature, which is located to the lower right corner of your screen. If you've not yet done so, please enter your audio PIN followed by the pound sign. So while lines are muted on our end, as a courtesy, please mute your line during the presentation. As a reminder, today's call is being recorded on Wednesday, September 30th, 2015. Welcome to ICD 10 Part 3, Checklist for Success, presented by the Visiting Nurse Associations of America. This continuing nursing education activity was approved for 1.75 contact hours by the Maryland Nurses Association and accredited approver by the American Nurses Association.
Re-enter your access code followed by the pound or hash sign.
Following the webinar, each registered participant will be emailed a link directing them to an online quiz and evaluation. In order to receive your certificate of completion, you must attend this webinar in its entirety and complete the online quiz and evaluation you receive via email. You must earn at least a 70% on the quiz to receive your CEUs. Please ensure all contact information you enter is correct, as this is where we will email all certificates. We ask that all online quizzes and evaluations are completed by Wednesday, October 14th, 2015. Our faculty, Sharon Litwin, has disclosed no conflict of interest. Sharon Litwin is a founder and senior managing partner of 5 Star Consultants, a national consulting, education, and coding firm specializing in home care services since 2003. Sharon has been in the home care and hospice industry for over 30 years. Sharon was also an HCS-D surveyor until December 2013 and a former CHAP surveyor, performing Medicare deemed surveys for almost 10 years. In her consulting firm, she assists agencies in providing quality meeting regulations.
It was miserable.
It'll be 2 weeks on Friday. I don't know, I'm stellar attack this weekend. It's not
Sharon and her staff perform coding OASIS reviews, clinical record reviews, do mock surveys, and help agencies across the country stay in compliance. Sharon regularly speaks at national and state associations and does frequent webinars for education firms on many topics integral to being successful in the home care and hospice industry. If you are on the line, can you please mute your line so that there is no feedback on this end? And Sharon, you can please go ahead with your presentation.
Thanks, Heather, and thanks everybody for joining us today. This is part 3 of our ICD-10 series, and what a date to have it on 9:30. Tomorrow is actually the day. If you've been asleep, well, wake up. October 1st is here. It's amazing. I feel like that. That's me. We've been doing dual coding for so long now. I am a coder. I have a consulting company that has a pretty large coding division, and so we do the outsourced coding. And boy, I'll tell you, dual coding has been just a nightmare because it doubles your time. And so I know all of us, I probably have about 30 RN coders in my coding division. We are all so happy for October 1st to start so we can stop doing dual coding really soon. So if you have hospice, you should have been doing dual coding since July 3rd. Now, a lot of times hospice, maybe those patients won't still be alive at October 1st, so you could certainly do them on the ones you think crosses over. And then August 3rd for home care for those research that will cross over. So obviously, no matter what system you're in, it really does take a lot more time. There are so many agencies that just are not ready. And I started teaching this class a long time ago now. But just because tomorrow's October 1st, it does not mean that it's too late to get started, because this is going to be a gradual transition as far as knowledge and many other things that we'll talk about today. So if you don't think that you're ready, we'll help you today to get on the right track so that you know what you need to do. I'm going to talk about the biggest challenges that I see for implementation, how to do an action plan to overcome those challenges. I'm going to go over a checklist for success, which is actually an action plan. that you can absolutely use. And again, I just want to say, you know, I've had some agencies say to me this week and last week, oh no, we're so not ready. What are we going to do? And so rather than panicking, I'll try to lay this out for you. And if you're listening to this recorded session, the month of October, the month of November, it is okay because we're going on for a long time on ICD-10, and even if you're not ready right away, you will get ready. All right. So do you have a plan in place for all of the processes that will be affected? If not, at this point, you're probably going to see some glitches along the way that then you can tweak. And so let's get a plan in place on this action plan so that you can be proactive. You're going to need a lot of continuing training. Just because the switch goes on tomorrow does not mean that everybody is well-trained and knowledgeable. You can't imagine how much training I've had, how much teaching I've done, how much coding I've done. And it has really taken a long time to start to feel comfortable. Are your vendors ready? Like I said, you should have been doing dual coding. Now, I have found out in the last weeks that there are a lot of agencies that have not done dual coding. The reason why I know is that they've called us and said, oh my goodness, can you help us? Can you code all of our active patients that are crossing over to October 1st with ICD-10 because we haven't done dual coding? I literally had one agency, actually two, that had over 100 patients that we needed to just drop in the ICD-10 codes for because they hadn't done dual coding. So again, if you haven't done that, don't panic. You just need to drop in the ICD-10 codes from the start of care codes. What about your referral information? I did an on-site session on this last week for one of the state associations, and there were about 60 people in the room. A telling thing was that there was standing room only, and so you know how many agencies aren't feeling ready. Well, I asked them, how many of you think that you are getting the referral information that you need on at least about 80% of your referral sources? And not one hand went up, so we know that's still a challenge. Have you made a decision on whether or not to outsource your coding? I'll go over some pros and cons with you. Are you getting your in-house coders ICD-10 certified? And are your field staff doing the appropriate assessments that are required in ICD-10? So those are a lot of the questions you need to ask yourself, because then you'll know what parts of this plan you need to really work on. Excuse me. All right, so don't worry, don't panic. I've been calling it the ICD-10 panic because for about 3 weeks now, we have gotten so many new coding clients. We've gotten so many calls from people who are just in a panic. And I just want to say to all of you, take a deep breath and relax. We'll get through this. An assessment of your agency is key. You really have to look at every area of your agency, and I'll talk to you about how. You have to have a leader for the plan. A lot of agencies aren't ready because they really didn't have a plan in place. If you're a small agency, maybe you're the administrator and you're doing it all. If you're a large agency, you want to be sure to have a team in place with a leader. And at this point, you can assess which of the following areas you still need to work on. You know, definitely staff knowledge base, referral info, software vendors, your financial status, and the dual coding. All right. So when I talk about a checklist for success and I talk about an action plan, which is really what it is, I'm really big on action plans. Whenever we do mock surveys for agencies, we do an action plan very similar to this. I've been a surveyor for 10 years, up until the last year, both with CHAP and ACHC. And, you know, it's very important that you lay out what has to happen for an agency to succeed by doing action plans. And basically, as a result of surveys, your plan of corrections, that's what they are. That's what they should be. It means that it's working tools. So taking that same concept, or from your QI model, same type of thing, you have your main topics, you have the details for each of the main topics. Responsible parties, very important, because you have to know who's accountable for getting this done. A due date, excuse me, I'm sorry, I'm getting over a bad cold, and so I'm going to try not to stop and cough and drink, but I may have to. The due date, and then the completion date, because this is a working document, so you do want to look at, well, we might not hit the due date was October 1st, and we have not hit that. So now our knowledge deficit, maybe we are taking different approaches, and maybe our completion date is going to be January 1. So what are we going to do in that meantime? Well, maybe we're going to outsource till January 1 till we are getting our coders trained and certified and the rest of our departments ready. And then, of course, comments. So this is what we'll be going over for each area. I'll show you other samples of this as we get specific. So, you know, just some basics. If you don't know a lot of the differences between ICD 9 and 10, one of the huge reasons why this is such a challenge is look at those numbers. I mean, 14,315 codes in ICD 9, that's a lot. But we're going up to 69,099 diagnosis codes. Something like as simple as a skin tear on a patient is one of the hardest things for me to code. It's a 7-digit code starting with S, ending in D, with all kinds of numbers in between. There are so many you know, codes that could be chosen for that. And so for me, you can think that if a skin tear takes so long to look up, I mean, it's because we have 69,000 codes. The other thing that makes it so difficult is that because of that many codes, there are what they're calling one-to-many matches. In other words, you may have one choice for a code in ICD 9. You may have from 5 to 200 codes in ICD 10, 200 in the case of fractures. The 7 characters, it really can get confusing with 7 characters. And the 7th character, you want to know that we will virtually never use an A. An A is initial encounter, and that's just not us. So home care and hospice, so extremely rarely would you ever put an A down. We are D. We are subsequent encounter. And then we use S for sequela, and you can think of sequela equaling late effect. We don't have anything called late effect anymore. It's called sequela, or plural is sequelae. Some of the time frames have changed, and so you have to really note that. One of the things that you have to do in ICD-10 is you really have to look up the codes. You can't just do it off the top of your head, at least for a long time. You know, I'm getting to the point now where I have probably 50 codes in my head that, okay, I know the rules. But until you know those rules, you have to look it up because there are many different rules and guidelines than in ICD-10. They are excludes one note. When you see an exclude one note, which you do under most of the ICD-10 codes, you can never code them together with the code that they're listing there. Excludes two notes can be used together in some circumstances, but they give you those. There are a lot of other guidelines and rules at the front of every chapter. It's just a lot different. They're sorted different, so it's harder to find. An example is injuries are now grouped by anatomical site. So you really have to do a paradigm shift on how to find the codes. You can't use just the crosswalk from the vendor, and I've heard too many agencies say, oh, dual coding's been a piece of cake because our software company puts it right aside. Well, the thing is, that's not taking into account all the rules, all the ICD-10 codes compared to that one ICD-9 code, and how we really are supposed to be coding specific now. Placeholders are confusing, and even to this day, I'm still confused on some of the codes that I looked up that then I think, oh, I need to put an X. An X is a dummy code. It is solely there so you can get to the 6 or 7 digit as an example. Let's say it's a 7-digit code. We know D is going to go into the 7th character, but the code itself is only 5 characters long. So what do? You can't put the D in the 6th character. If you do, it will be bumped back to you, or what is called RTP, return to provider, when you bill it. And so the reason why that is because it's a 7-digit code. So all the X means is that there is no number there, no letter there, but we have to put it to get to the 7th character. Very confusing. All right. I think there are 4 categories of our biggest challenges: knowledge deficit, your IT systems, your referral information, and financial considerations. So that's what we're going to talk about. Communication is also can span all 4 of those areas. It is just so critical that all of your staff and all of your senior management are very involved. This is a huge change for our industry as well as the whole entire healthcare industry. And so communication is very important on the timelines, on who the leader is, any system changes, and lots of process changes. I talk to a lot of agencies as I'm teaching and doing clients, getting them started on coding, where their field staff aren't even aware of some of the things that have to be done. One case in point especially, non-pressure ulcers having to have the depth documented. Otherwise, the coder can't code. And so that's getting kicked back so often. And the staff, not only did they not document it, but they don't know it, so they have to go back out and look at the wound and put it in. So things like that, that communication of changes and what you need is very key. Senior management will talk a lot about, the cost of this, the financial considerations going forward, so they have to be very involved. This is an organization-wide change that's starting tomorrow and actually has already been in place. So have you been doing dual coding? I told you what you have to do if you have not. You have to really start to code all of your active patients in dual coding, because otherwise when you do a final claim, you won't be able to submit it. And so think of how much that will hold up your billing if at the time of final claim you have to have someone go in and look at the start of care diagnoses codes and then enter the ICD-10 codes at that time. So you really want to take a look, if you haven't been doing dual coding, on all your active patients and drop those ICD-10 codes in now. If it was a vendor-related reason, goodness, that's not a good thing. And yet I know of several software systems for home care and hospice that were not ready on the dates that they needed to be. Several didn't start till the very end of August and the beginning of September. And so, the challenge there is that you weren't able to dual code prior to that. So now those are the patients that you would have to do now. Any vendor that wasn't ready for dual coding, you really have to look at closely, because they've had a long time to get that ready, and so many vendors did have it ready. Now, a lot of them didn't do a great job with it. It takes you absolutely double the time. There are a few that did make the steps less. So you want to look at those kind of things with your software vendors and really let them know the things that you have found about this transition that they have really dropped the ball on, because you want to make sure that they are ready now. You can't assume that they're ready. You have to really look at what they've done. Look and see on their websites. Does it tell you? Do they have user groups? Really find out, because you don't want your software system to make your productivity worse, to make your billing cycle worse, on and on, because ICD-10 with a well-working software system is going to have major impact. You can go on to the cms.gov website and the section that's related to the vendors, so your software companies. You can look at that area, and they do have some good information, whether you're small or large, whether your vendor's small or large, so that you know what you should be asking them. But this ICD-10 website is really important as well, because it has a lot of good information. It has all the latest news. In fact, I really do need to go on that again today. I check it about every week or two just to see if there's anything good news or bad news. Now, a lot of things I get already from associations, like unfortunately that we don't have a grace period. We keep hoping that we would have a grace period like the doctors do, and NOC has really been pushing for that. And just a couple of days ago, maybe yesterday, CMS, gave a quote that said, no, you're not going to have a grace period. So it's really unfortunate with that. Those of you that don't know, physicians have a grace period for a year. And so that means if they enter wrong codes, they won't be dinged financially, etc., like we will be. We will, the rest of the healthcare world, except for the physicians, if we put a code in tomorrow that is wrong, it'll get kicked back for billing. And if it's reviewed a year from now, let's say that they ask for an episode starting October 1 a year from now as an ADR. When they review that, if wrong codes are on, they'll deny it. And so they're not giving us any grace period at all, unfortunately. But that's where you can find things out like that. There's a lot of provider resources you can look at, and that's where the GEMS are. The GEMS are generalized equivalency mapping. It has every one of those 69,099 codes, and across from it is the ICD-9 code. They say over and over it is not a crosswalk, because they don't want you to take a simple one-to-one match, but basically it's laid out like that to say that 781.2 gait abnormality is the one code, and now there are 6 codes under the R26 that are for that you choose from. So every single code is in there. I don't recommend to get into that and use it heavily, because it is difficult to download and to work from, but you may want to see that to see all the codes that there are. So the action plan checklist for your IT software system, you want to make sure who you communicate to. Make sure that you have someone that you can get to. A lot of agencies do not do that, and that's very important. You want to have direct access, not just putting in tickets. So what testing have they done? Are they ready? Are there going to be upgrades? There is one of our clients that's on a big system, and they're a big agency, and their upgrade is starting tonight. I mean, that is so late, and there's nothing you can do about it now. Of course, I talked about the dual coding. How much training will they provide? This upgrade that's just starting now, I would expect that they would really set up a lot of training, because, who has time with October 1 going in place to actually have to learn it on your own? There should be a lot of information on their website. If there is, be sure that you have someone dedicated to looking at that, to find what are the bugs, what are the glitches, what are the workarounds, what have other users said, when are they testing, and on and on. There are some systems that have very good information on their websites. And then what have you done as far as testing? Well, you do still have some time, because obviously the ones that have just been put in for start of care, whatever, it's going to overlap. And so You know, how are you working with payers? How are you working with your clearinghouses? And so a lot of the testing, although we're starting October 1, you still have some time before you will be billing and having to dig into that for real so you can have your billers test all of your payers, making sure they are ready. All right. So how are your departments affected? Well, obviously I'm not hitting every one of them, but a huge department that's affected greatly is referral intake departments. You really have to make sure that you have a dedicated, accountable person in charge of meeting with your referral sources. Now, you might have 5 referral sources, maybe let's just say they're your hospitals, and they are giving you good information. Maybe 2 of them, though, although they're giving you a lot of information, they're not giving you what you need for ICD-10, such as a discharge summary or something after the H&P. Because keep in mind, in H&P, a lot of those diagnoses may be preliminary and ruled out. And so, goodness, where do we go from there? A lot of your non-specific diagnoses may now be specific, which we then need to document in ICD-10. So on those referral sources, those 2 hospitals, you want to meet with whoever's giving you that information and let them know the additional information that you need. The nice thing about meeting with the hospitals are they need that information as well. So they just have to know that you have to have it too. Now, let's say that the other 5 referral sources that you have are doctor's offices, and you still don't get much information at all from physician referrals from their offices. I see that all the time yet, and those seem to be the weak link. But, you know, the physicians need to have that too in their records. Now, unfortunately, I talked about the grace period, so some of them may not be taking it as seriously as they should because they know that it won't affect them yet. However, a lot of them will. A lot of them will put the information that is needed. So you have to go meet, or your dedicated party, your responsible party for this, needs to meet with those offices and get to whoever is in charge of that so that you can get that information. You can't just have a referral from a doctor's office that says home health to assess blood pressure, etc. We need more information. So, dressing changes to leg wound, that's not specific enough. A hospice patient. I have one hospice that I code for that the medical director is constantly saying end-stage heart. Well, what really is end-stage heart? Well, we need a specific diagnosis. And then hospice, you need to have all of your specifics on your related and non-related diagnoses. I do a lot of our hospice coding for our company, and, you know, hospices just 2 years ago, they were only required to put in primary terminal diagnoses. And prior to that, most hospices never put more diagnoses than that. And now, my goodness, not only do you need the primary terminal, but you have to be very specific on all of the related and every single non-related diagnoses. It's been a 160 or a 180 paradigm shift in hospice, making it very difficult. And hospice patients have a lot of codes. Yesterday I coded 3 hospice patients. It took me so long because they had, each of them had like 25 plus or minus a couple ICD-9 codes that then I had to do 25 ICD-10 codes. So it's a lot of work for hospice, but if you're with hospice, you have to know that you have to do that. I think a lot of times hospices are weaker in ICD-10 preparation just because the coding part is so much newer to hospices than it is for home care. Okay, so if intake doesn't get good information, then it has to be left to your admitting clinician to get this information when they're out with the patient. that will require longer visits, calls to the physicians, a lot of due diligence to really track this down. Now, let's say your admitting clinician doesn't do that, and then your nursing supervisor doesn't do that. When it goes to the coder, whether it's a coder in the cubicle 5 cubicles down from you or coming to me as an outsourced coding company, it doesn't matter. The coder is going to be looking at this information and saying, I don't have enough information to code. And so then that's going to be going back to the supervisor and the clinician saying, you're going to have to give me more information. You have to query the physician, or you have to find this out on another home visit, but I can't code from what you're giving me. If that happens, think about it. How much of a delay is that going to cause on getting your OASIS locked, getting your 485 out the door? Both things very important for compliance. And getting your wrap out. So your cash flow is going to be so much longer. And so it really takes that referral intake department to try to get as much as they can at the front end. Now, intake staff also have to have some knowledge on ICD-10 coding, because an awful lot of systems require that on intake there are codes in there. And that's very true of non-Medicare when you're working with insurance companies. And so you need to be sure that your intake staff at least have training on maybe your top 20 diagnoses. That here is a cheat sheet. That yes, CHF 4280 equals I-15.9, but then there are 20 others more specific. We should be using a more specific code. In all cases in ICD-10, you want the most specific and not unspecified. So they do need to have that training. But I really have found that if it is the top 20 and you give them this cheat sheet with all of those in there, it makes their lives easier as they're talking to the referral sources. If you have a referral source that absolutely won't give you enough information no matter how hard you try, let's say you have a doctor's office that says, no, we don't have anything to give you. The doc won't tell us to give it to you. You just have to go out into the patient's home and then call us for orders. Well, you might not have enough documentation. So that's when you have to go to administration in your organization and put it up a level, because you don't want that to be on you if you have inaccurate or insufficient documentation and you end up getting a lot of denials a year from now. All right, well, of course your billing department is affected major. Medicare expects a spike in rejected claims 3 to 6 months following tomorrow, peaking at 10% of all claims submitted. That is a lot. Just think about rejected claims for you. Your RTPs, which is a rejected claim, return to provider, I'm sure you don't have 10%. That's a lot. And what an RTP is, what it means then, the biller has to go back to the clinical team, the clinical supervisor, back to the clinical assessing nurse, back to the physician, on and on, to get the specific information to put the correct code in. Now, if it's a wrong code due to knowledge deficit, the biller is still going to have to go back to the coder and say this was rejected, so you have to dig into it. And those have to go to the top of the pile, otherwise your cash flow is going to be terrible. So, your billing staff, if you haven't, you really have to train them well for crossover claims. A claim before October 1st has ICD-9 codes only. A claim October 1st and forward has ICD-10 codes only. Very big deal. You have to make sure your codes are following coding conventions. If they're not, they'll either be RTP'd to you or they could be denied later on. And those are all the manifestation etiology codes, the combination codes, For instance, putting the correct code for hypertension in chronic kidney disease before the chronic kidney disease. Many agencies don't know these conventions, and it's very important to know in ICD-10. And I'll say for hospice, again, this is so new to hospices that many times I'm having to go right to the medical director as a coder and say, because they're coming to me saying, I didn't put hypertension as the primary terminal diagnosis, I put kidney disease. And so that's when we have to teach them that in coding, that hypertensive in chronic kidney disease has to go first. So there are so many rules in our coding books, in our coding in ICD-10. And they're called coding conventions. Obviously, we need to do the best we can for timeliness of billing, so all of these examples will slow you down. So you want to have all your staff as much knowledge, get as much information as possible. Now also your collection staff, when they're collecting, you have to really teach how you're going to handle denials promptly, who they go to, what that time frame is, incorrectly submitted claim, that process I talked to you about, so how do we get that billed right away, and be on your max mailing list, email list, as well as check their website frequently. You know the max are going to have issues with this transition, so find out about them right away. Finance. Okay, I talked about the no grace period. So, for your CFOs, they're cringing at that because they know that we're held responsible to be completely accurate starting tomorrow, and that's not going to always be the case. How is your finance department set up to address decreased cash flow, increased AR? There is a projected 50% decrease in productivity in the first 3 to 6 months. Now that's of coders, so you can imagine all of the items that I said can hold up coders, not getting enough information being a big one, and having to go back to the clinician and then to the physicians for more information holds things up a lot. Also, it takes longer to code ICD-10. I've been coding for 8 years. I manage a coding division in our company, and it is slow going. I don't think, based on what I just heard, that we will ever come up to the same level of productivity that we have in ICD-9. We dropped the number of assessments a day that coders have to do because of this. I heard just last week when I was on site, another consultant told me that in Canada, they have been on ICD-10 for about 3 years now, and they are still down 40% in productivity in coding. So that shows you how difficult ICD-10 is. It's all the many rules, and it's all the huge number of codes. How can it ever be that fast again? And so the thing is, finance has to look at that and say, geez, our productivity is going way down, and our cash flow is going way down. And we're getting tons of codes kicked back, and we're going to have a lot of denials. So you have to be involved with your finance to say, okay, do we outsource for the expert knowledge? Can we increase staffing quickly? We have to perform audits on our coding. I'll talk about that later. And we have to have reserves set up. There's going to be glitches. There's going to be decreased cash flow. There's going to be decreased productivity. So be prepared. Immediately 40 to 60% decrease. Now, if you've been doing dual coding, you know that that's been even higher, because this is talking about just ICD-10 coding. And goodness, it has doubled our time doing ICD-10 coding. Now, one of the pilot studies that was done that is the most remarkable to me is that AHIMA, they've really been leading the charge on the ICD-10 transition for many years now, but about 2 years ago, AHIMA certified ICD-10 trainers. They were people who are very experienced coding, so they weren't new to coding, and they not only were ICD-10 certified, but ICD-10 training certified. They did a pilot to see how the coding productivity and accuracy would be. There was a 50% decrease in productivity by these experts. The thing that bothered me way more than that, which I already knew, was that doing it with 50%, so in other words, they were doing half as fast, they still only had a 63% coding accuracy. So that shows that this is not easy. When you have experts like that have slowed down that much and still were only 63% accurate. I think a lot of agencies are taking it way too lightly because of how difficult it is. And I can say that because I know as a coder. All right. So what it is advised for your finance to do is calculate the revenue each coder brings in each day and how much a 50% drop in productivity is going to impact that cash flow. That will help you know how much reserve you have to have on hand, or if you have to get other financing options so that you don't run into severe trouble. All right, QI. Well, your QI people have to have knowledge of ICD-10 because if they don't, how are they going to review? They're not going to know if the documentation and the diagnosis codes on the 485 and OASIS are matching. They're not going to know where there are errors. And so it is important for QI to have a relatively good level of knowledge of ICD-10 prior to, I was going to say prior to October 1st, but that is now. I just got off the phone with one of our new coding clients. We started them 2 or 3 weeks ago, and it is a VNA. And now I got off the phone, and the director said, we really are going to have your help with QI for a while as well, because we realized that, you know, we're not up to par with ICD-10, so how can we QI? And we do so much remote QI analysis, data collection, reports, etc. for clients, but this is something that we did know was going to increase along with our coding outsourcing increasing, simply because a lot of agencies haven't thought about how QI really depends on having ICD-10 knowledge. So that's something you're really going to want to look at and get your QI staff trained if you haven't done that yet. Our documentation is already being scrutinized to such a higher level with our survey processes, many more deficiencies, many more condition level deficiencies, and immediate jeopardies being given, which result in sanctions as well. So we're already having challenges with our surveys being so heavily focused on documentation. Obviously, it's for patient outcomes, but the documentation is a huge piece of that. So now it's even going to be scrutinized to a higher level because of ICD-10. You have to match those codes with everything that is said in the OASIS comprehensive assessments and in the visit notes. And it's kind of hard if we're not coding correctly. So I really am a proponent on peer clinical record reviews as well in your QI, because it so helps educate your staff dramatically when you do that. So don't forget, if you have some of your staff that have been trained onto QI to do clinical record reviews, they probably need a more heightened knowledge of ICD-10 as well. Now, your field clinicians, and a good segue from that, you know, I talked a lot about what your clinicians need to get. We really have to have specifics. And so if your assessing clinician, your RN, is out there and, you know, just, taking things from med bottles that your patients are telling them, and not having a query to the physician for confirmation. Oftentimes you will not get the specificity of the diagnosis that is needed. That example that I gave still happens a lot. I know some agencies would be shocked that that's where and how they are getting the diagnoses, but many have no other information, and they haven't had their administration, work with the physician's office to say, we need this information. So now these nurses and PTs are going to have to know that they're going to have to query the physicians for more specificity. Your OASIS has to go along with this. And like I said, there are some very specific needs in the wound areas, definitely in the wound areas, but many other areas as well. And, I do a lot of OASIS training, and I was, in fact, in Virginia, I guess it's 3 weeks ago now, doing a 2-day OASIS seminar. And really what they wanted the seminar for at first was ICD-10. Well, I can teach you that in 10 minutes. But the OASIS C1 ICD-9 that we started in January, and just OASIS C before that, there are a lot of clinicians that do not understand the CMS intent of the questions. And so the integrity of OASIS is not good. And I have been doing a lot of webinars and on-site seminars on OASIS, because that is the core basis of home care. That's your reimbursement, it's your compliance, it's for your surveys, and it's for your outcomes. And now with the outcomes having the 5-star ratings, which will lead to reimbursement very quickly, it's even become more important. Well, ICD-10 is in OASIS. It's for the reimbursement, and it's also for your compliance of how does it flow for everything else. And many of the OASIS questions are being answered incorrectly because clinicians don't understand what they're supposed to be answering. Case in point, ADLs and IADLs. Safely, just safely, is such a big factor where so often clinicians, especially nurses, will score patients too independently because they're not taking into account safely. Then the heart failure and the medications with time frames of when physicians have to call you back in order to answer yes. A lot of those areas are still very weak. So I'm saying have back to basics clinical documentation and services now. You can address ICD-10 areas that clinicians have to know, and you can also address OASIS and documentation along the way. I think it's very important. Field staff probably need diagnosis codes for your lab requests, auth forms, DME orders. A lot of agencies, your medical supplies, a lot of agencies do. And so, of course, there again, they need to have a list of your top 20 diagnoses. All right. Okay, so coding, of course. Now, you have to train any non-clinical coders in A&P as soon as you can, because so much more A&P, anatomy and physiology, is needed. Clinical knowledge of diagnosis, so much more is needed for ICD-10 than before. So if you have non-clinical coders, they could be putting unspecified codes and not knowing. I've seen several of our clients that we've gotten in the last few months where non-clinical coders are not only putting unspecified, but where laterality comes into play. We always need laterality now, whether it's the right or left leg, etc., and very specific, up on the back, lower on the back, on the right side, on the left side, etc. And they're putting unspecified, and you just can't be doing that. But then even past that, that A&P knowledge is necessary, because now they'll say, oh, okay, it really isn't CHF unspecified. First I have to put the diastolic heart failure followed by the unspecified CHF. So those types of things are very important. There are a lot of on-demand type of courses that are on the internet under our, reputable education companies for home care, that you can get A&P classes for coders. I have nothing at all against clerical coders. I know some clerical coders who are wonderful, but I feel that to tie the OASIS, the diagnoses, the H&P and discharge summary and face-to-face, and really have that picture together, that clinical coders really are what I feel should be. We have only RN coders, and it's because they're the ones that are trained in the OASIS and that whole assessment process. A lot of outsourced coding companies do not. They have maybe 10 non-clinical coders to 1 RN coder. And if you have non-clinical coders, that's fine. Just be sure you're giving them the training that they need. Prepare your coders for the ICD-10 certification test, even if you're not going to have them take it yet, because the amount of study that you have to do to pass this test is very high. And so you will have study guides that will, you'll work through to know the rules, know how to get the codes, know how to match the codes up with what they have to be, and know the differences between ICD-9 and ICD-10. That will help with your productivity. The test itself is it's brutal. I just keep saying it's brutal. It is very complex scenarios with a lot of codes. So in other words, multiple choice, complex scenario, A through E, and then about 7 codes on each of them, A through E. Now you can rule some out, but then you have to look everything up. And here's the really hard part is, even for me, I studied and I've been teaching so much and I've been doing so much. It was difficult because you're on such a tight time frame. It doesn't sound like answering 50 questions in 2.5 hours should be that hard, but think about it. Think about our productivity I've been talking about. That is very difficult because, in my opinion, the time frame is way too short. Everybody that I have talked to who has failed because they didn't finish the test. And so that's the thing, that you have to be very knowledgeable about ICD-10, and then you also have to really pace yourself to go fast. Here's another thing that can show you how difficult ICD-10 is. This is an ICD-10 certification test, and the passing score is only 74%. Now, when do you ever see a passing score that low for a certification test? Usually it's 85%. So you just know how hard ICD-10 is to learn. At least 50 hours of training needed for your coders for ICD-10. And, Medicare and a lot of the study groups put out a lot less than that. I have to tell you, for me and my coders, we've had a lot more than that. All right. So training. If you haven't trained all the departments to what they need, that's what you have to see. You don't want to train everybody on everything. Not everybody needs 50 hours. Some people, some departments only need certain pieces. And that's what you want to do, is you want to make sure that every one of your positions and departments have what they need. Now, the training doesn't stop tomorrow. It's complex. You keep going. Keep giving scenarios. Keep making sure that their A&P knowledge is increasing. Make sure that they understand the conventions so it doesn't stop tomorrow. If you don't have good coding resources, you definitely need them. If you don't have a 2016 official ICD-10 coding manual yet, get it today. They all were pre-ordered, and we got ours about 3-4 weeks ago now. Don't just rely on the preliminary manual. I've had some agencies ask that, but that was over 2 years ago, and there's been changes to that. One agency said to me, well, we don't want to buy another manual. Can you tell us the changes and we'll add to that? And, of course, my answer was, No, you buy the $200 manual. You need that. Now, there are interactive websites. I'm not selling for Decision Health. I'm just telling you the one that I use and my coders use. It's a Decision Health Coding Center. And for my, I think personally, it has increased my productivity in ICD-10 dramatically. It has everything in it that the books have. It's just much quicker to get through. Now, I do have some coders who are still married to the book and they won't give that up, and they can do it pretty fast. So obviously it's preference, but you might want to take a look at the interactive websites. Keep in mind, I'm not talking about Google. I taught this several months ago, and I had an agency contact me afterwards that say, I don't know how you're getting enough information from the Google search engine for the codes because all the rules that you set aren't there. Well, I'm not talking about Google. Google might be a great way, for me, I'll tell you when I use Google and when my coders do. Somebody has an abbreviation for a code or a syndrome very often that I have no clue what that is. And sometimes I've seen physicians write it, and so then the clinicians carry it through. No clue. Well, you know, the bad thing about the coding manual and the coding center, it's like a dictionary. If you don't know the word you're looking for, you don't know where to look. So I'll tell you, Google and the other search engines are very good for putting a code, an abbreviation. I can't right now. Well, let's just say CHF. And let's say you didn't know what that was. And so, you know, it will have in the body of many of the things you search for congestive heart failure. And that's what's nice about that. But that's not what I'm talking about. I'm talking about one that mirrors the book. Now, also, again, Diagnosis Coding Pro is a Decision Health product. Again, I am not selling for them. There are many others out there, but that's the only one that I know that is like a quarterly magazine. And so it really tells you what agencies have seen, what denials and RTPs have, what are problematic areas to code. Those types of coding magazines are very critical because they really help you keep up. And you learn from others. And then quiz books for ICD-10 scenarios. If you're doing your own coding, don't stop, because you need to assess your competency of your coders. And so you want to have quiz books that have ICD-10 scenarios that they can work through. So this part of your action plan, checklist for success, is on knowledge deficit. So what you want to do is have it broken down by position and department. Assess your knowledge, your staff knowledge level for their position requirements. So, of course, coders are the most intense. Intake. Now, today, and again, I'm not selling outsourcing because I'm going to tell, for myself, I'm going to tell you pros and cons, but if you know today that your coders are not ready for ICD-10, that is the time to say, goodness, we better outsource. And that is why I'm getting so many panicky calls from agencies that need help right now. Maybe they won't for the long term, but they're not ready yet. And then break it down to every one of the other positions: intake, admission clinicians, other field staff, billers, QI, clerical staff. I don't have management on there, clinical management, administration. And then identify who needs AMP training and go online to look at companies for that. And then make sure that whoever's teaching ICD-10 is really an expert. I've seen some agencies have someone from the agency attend a webinar or a 2-hour on-site class that I gave at a session, and that's their expertise, and now they're train the trainer. Please understand, it takes a lot more knowledge of ICD-10 to be able to train. Otherwise, they could very well be teaching the wrong things. Look for online classes, webinars, on-site seminars. Although I teach ICD-10, I, of course, am constantly learning things about it. And I have purchased so many various online classes, so I have a variety of speaker experts And I have some that are a series of handouts and CDs, others that are on demand online. There are still a lot of on-site seminars being given. So if you feel like you're not ready today, but you want to, I talked to someone last week at the state conference I was at, and she was going to be attending an on-site this week. And that's great. Go next month if you have to. You don't want to stop your training. Test staff on their coding abilities with scenarios, and that will be your competencies. I recommend those at least weekly to start with if you're doing in-house coding, then drop to monthly, and then keep it at quarterly competencies. I talked about having your coders prepare for the ICD-10 test, even if you're not ready to get them certified. Dual coding, we talked about, is certainly a help for practice. It takes so long, and I'm so glad we're going to be done with it soon, but it has helped me get used to ICD-10 tremendously. All right, so if you haven't already, I've talked several times about your top 20 codes and do your top 50. Run reports to say what are your most common. Now, take that ICD-9 code and put all 10 ICD-10 codes aside of it. Do not put one aside of it. If you put the unspecified code that pops up first aside of it, many times you will be losing a lot of reimbursement. Sometimes that will be RTP'd to you, and a lot of times it will be denied in the future. So be sure that you have 20 ICD-9 codes, but that might be 100 ICD-10 codes. All right. As you code, you can make these. That's what I've done. I have, especially for hospice, as I go along, I do a lot of that with the dual coding. So you have to look codes up. I said that again, but it's worth repeating. If you think, oh, I know this code by heart now, but you don't know the excludes one notes, maybe right after it you're putting a code that can't be coded together with it. And if you do that, that could be RTP'd. Definitely could be denied. It's very important. The coding conventions are really being enforced with ICD-10 even more than they were with ICD-9. And there's many more of them. Very important compliance issue is that if you have in-house coders or you have outsourced coders, the assessing clinician is responsible for the diagnoses put in the patient charts with the physician's collaboration or recommendations, of course, approval. If a coder is putting codes in when they don't have specific information, putting the best logical guesstimate, that's out of compliance. You need to make sure that the coder is communicating with the clinician in writing. So in your EMR is many times how we do that, and how your in-house coder can do that as well, where the coder's saying, do you agree with these diagnoses, basically, and the assessing clinician has to say yes. If the coder knows that the conventions and rules are being broken by what the physician and the clinician gave, the coder has to go back to them and say, look at, like the example that I gave, you want CKD, but the patient also has hypertension. We have to use a different hypertension code, and we have to put it before the CKD. So you have to have your coders doing that so that the assessing clinician and the physician are aware. That can be done in documentation, and so it's not as hard as it sounds, but it's very important for compliance. Okay, so to outsource or not outsource. I have had a consulting firm for 12.5 years now, and about 7 years we started a coding division, and it's grown tremendously. But I have a whole lot of consulting clients who don't outsource their coding. And so I see it from both sides most definitely. And what I want to tell you is that there are a lot of pros and cons. Advantages for you, or the pros, are definitely cost and time for training your own staff. In addition, when you outsource, you want to outsource with a company where you know that these are experts. And so your error rate will be much less. And if it's not, you have to change coding companies. You only pay for what your volume is, so you don't care if my company's productivity has gone down the drain. You're still just paying me for the volume, where if you have 2 coders who previously could do 16 a day and now they're down to 10 a day, you need another coder. Time frame for completion, same thing. Your outsourced coding company should have a time frame in there. Now, that's not to say that with dual coding we miss that time frame sometime, because my goodness, but you should have a tight time frame. We have a 2 business day time frame. And so again, your billing, your compliance with getting your 485 and your wrap out the door should not always be bad as if it was in-house. Now, I'll tell you why I said should not always be, is because if you tell me Mr. Jones is ready to review and code, and I'm going through the referral information, you know, the H&P, all of that, the face-to-face, the OASIS, the narrative, and I don't have near enough information to code, I'm going to send it back to you. You're going to send it back to the clinician. The clinician's going to call the doctor, and on and on. And so then the time frame is the same, but at least when you have that information, the time frame is quicker. The demand for coders obviously is going way up. I have hired probably 8 coders just in the last 2 months, and I think it's 5 more coming on board. They're working out their notices. It's really increasing, and you can see why. It is expected to continue to increase up to 18% over the next 3 years in healthcare. So for you, it's going to be a lot harder for you to hire an expert in your area, in your city, versus for me, where I can select experts from all over the country. Now, disadvantages, it's like any new thing that pops up where people go, oh, I can get into this business. Well, guess what? There are a lot of coding companies popping up all over. I see so many more at every conference we go to where there's more and more coding exhibitors. I actually talked to a coding company last summer. I had known the people from the past life, and we sat down, and it was the owner and 2 of the directors. And we were talking, about ICD-10, and actually at that time I was looking about outsourcing to them to get some coders from them, because I was really short-staffed at that time with dual coding starting. And they told me all about coding that they're doing for agencies. And when I got into the real specifics to see if I could outsource with them, I found out that not only were their coders not ICD-10 certified, but they also had very little coding experience. And some came directly from hospitals, so they didn't have home care experience. So you really have to make sure you do your due diligence when you're signing up with an outsourced company to make sure you have a quality agency. There are just too many agencies popping up all over saying we can do your coding for you. Many have clerical coders. If you're okay with that, that's fine. But if you want clinicians, be sure to ask. And they might say, yes, we definitely have RNs. But then make sure that you find out, well, are clerical coders going to be doing it? And then the RNs review some of them. There are coding companies. There was a very reputable big coding company that a few months was doing an advertisement on an email blast, and it said, come with us, our coders, we'll do 20 to 25 assessments a day so you won't suffer with your billing. Well, honestly, I don't know how you can do that many a day. We dropped our quota from 16 to 12, and 12 for me, when I'm having to do a lot right now until I get the rest of our staff on, and of course we keep taking so many new clients on, I can't do 16 a day anymore. 12 is my max. And so how can a company say they can do 20 to 25? Obviously, you have to ask your coding company when you sign up with them, are you going to be short-staffed? How are you going to handle this? And make sure that your communication is very well written in a process so that that assessing clinician gives the final okay. And make sure, occasionally we get coding clients who bring us on. We review everything, including fine-tooth comb with the OASIS. We do the coding. And once we send it back, then a QI person does the same thing as we did. If you have a QI person doing that fine-tooth comb review of OASIS, maybe you just want your outsourced coding company to put the codes in. Then that's a much briefer review, and you're going to review the OASIS with a fine-tooth comb. So make sure you know what you want, because you don't want to duplicate. So here is the action plan for financial. And so it talks about a budget. If your budget's starting January or today, you probably haven't put enough out there for it, because it is going to be a long-term drop in productivity, cash reserves because of this, RTPs needing cash reserves, future denials, and then an evaluation of the cost-benefit analysis of outsourcing or not. Okay, so this to me is very important, that whether you're in-house coding or outsourced coding, have a third party audit your charts for the first 3 to 6 months of coding ICD-10. Maybe do a 20% review. And so if I'm the one reviewing your audit, what I'm doing, and a lot of our agencies are actually having us do that right now, because they have some coders, and then we're helping them because, you know, productivity, so maybe they have 4 coders. Maybe basically we are their 5th coder, and then they're having us do audits on their 4 coders. And that is very important to do, because you want to find out at the beginning, before you get denials, that you are compliant in coding. Because then, of course, you can have your training plan more intensified if you find a lot of errors. You want to make sure a lot of things, but a key thing for home care is that you are receiving the best reimbursement that's accurate to the patient condition. So that means not a lot of unspecified and not a lot of symptom codes. In hospice, you want to be sure you're following coding conventions. I see that as the biggest weakness in hospice, understandably so. So to get somebody to do that is very important, and then use that for education. So I talked a lot about all of our challenges. There are a lot. Are your coders competent with learning a radically new system? Keep in mind, you know, us coders, all of our memorized codes are gone. And me, you know, I'm certainly not a full-time coder, because I'm a consultant and I'm running, you know, the company. And so I have, gosh, I must have thousands of memorized ICD-9 codes. And basically I would love to just purge them from my brain now, and I can't. So obviously now we're starting to memorize ICD-10 codes as well. There are definitely, it's a given, CFO, that there's going to be productivity losses. And that's whether or not you're doing internal or outsourced coding, because remember, if you have to send it back because there's not enough information. Even I did a bunch over the weekend that one of our clients that we code for, they needed a whole lot dual coded that they hadn't had us do. And so I was dropping those ICD-10 codes in, and when I say it like that, it's because I'm just looking at their start of care ICD-9 codes and putting the correlating ICD-10 code in there. I'm not doing a review again. What I found out quickly is, yes, I am doing a review, because if they have a stasis ulcer of the lower limb coded in ICD-9, I can't code that. I have to go in and look at the OASIS. I have to look at the wound addendum. I have to know whether it's right or left leg, what part of the lower leg, and what is the severity of depth of that stasis wound. Now, a lot of times I had the location and the laterality, but never did I have the depth of severity. And I'm not going to guess. I saw the measurements, which probably I would know what to put, but So I would have to send that back, they do a lot of wounds, so I would send each of them to the wound care coordinator and say, sorry, but I can't put the ICD-10 code in until I know the depth. The depth of that non-pressure ulcer, so a stasis, diabetic arterial ulcer, is within the code. So you have to have that in your documentation. So those are things that are going to come up a lot. All right, so OASIS C1, ICD-10, I can teach it to you very fast because all they changed, thank goodness, was the numbers. They went from even numbers to odd numbers on the diagnoses. So instead of M1010, it's M1011 and so forth. Two changes. M1012 has completely been dropped off, thank goodness. That's the surgical diagnoses. And M1024 they kept. They call it M1025 now. However, we don't have to use that anymore because for fractures, which really is all we had using that anymore for the past year since they've changed it and you couldn't put resolved conditions there, we've been using it for fracture codes because we weren't allowed to code fractures. Now we have to code fractures. So in essence, we never need that. If you put anything in 1025, it could possibly be used for your risk adjustment. I say, do you really want to bother with it now when it's not necessary? So I think you'll be using it very rarely. Your M0090 date determines whether you use ICD-9 or ICD-10. And so, you may be doing a start of care today and finishing that OASIS today, so when the coder gets it tomorrow, then it's ICD-9. But if you start it today and finish it tomorrow and the coder gets it on the 2nd, it's ICD-10. You always pay attention to the M0090 date to know if you're doing an ICD-9 or an ICD-10 code. So that won't go too much longer, but you have to really pay attention to that. And, starting tomorrow, it's probably tonight at 12:01, you have to use OASIS C1 ICD-10. So make sure you're using that. All right. Case mix. I included this because a lot of home health agencies are saying, gosh, our case mix weight's gone down so much. What's happened? Well, we lost 201 case mix diagnosis codes in January with the final rule. And they were big ones. A lot of our pulmonary, a lot of our psych, which includes depression and all of that we use a lot, they're not case mix anymore. And we so hoped that some of that would be brought back with ICD-10 because it was really being challenged, but those still aren't. So, of course, our case mix is less because we don't have as many case mix codes. You want to get as specific diagnosis as possible because a lot of times the case mix codes are those that are specific. Unspecified a lot of times is not. So get the grouper or else, print off all the case mix. You can get it from cms.gov and lots of other areas. All right. I-50.9 CHF unspecified, they had threatened that would not be a case mix. That's our 4280. They left it as a case mix weight for now. Get used to coding more specific heart failure because I doubt if they will keep that on next year. All right. Hospice challenges I have talked about, but you really want to have all diagnoses because both of the drug implications, authorizations, as well as who's paying. Medicare really has said and has it quantified. I know I heard Bill Zombie talk maybe the beginning of the year somewhere that I can't remember the number, but it was an unbelievable number of millions of dollars that CMS is saying that they're paying for when it should have been covered under the hospice benefit. So they are really looking at that related and unrelated diagnoses, and that's why it's going to be going on to all the claims and you have to code a lot of diagnoses in hospice. And so you want to be sure you put a lot of thought into it, your IDG and especially your medical director, on what is related and what's unrelated, because that is being scrutinized. All right, so this was a lot of information. Make sure you have a transition plan in place with an assigned leader for anything you haven't done yet. And you want to update it frequently, have backup plans in case of glitches. So I ended with a few minutes left for questions. If there are any questions, Heather, I'll turn it back to you.
Great. Thanks, Carol. Thank you so much. That was great. Does anyone have any questions at this time? I'm going to go ahead and unmute the participant lines. So if anyone has any questions, you can go ahead. Okay, it doesn't look like we have any questions right now. I would like to take this time to thank you all for joining us during today's webinar. It's your participation and feedback on the post-webinar evaluations that allow VNAA to improve program offerings and activities. As a reminder, please have all quizzes and evaluations submitted by Wednesday, October 14th, 2015. I would also like to thank our guest faculty, Sharon, for sharing her expertise, time, and commitment to making this a successful program. Thank you again for your participation, and I hope you have a wonderful afternoon.
Thank you very much.
Thank you.